abdomen or in the upper abdomen in the midline. The main junction of the autonomic nerve supplying the upper abdominal organs. So solar plexus proper, it consists of the celiac plexus proper consists of the celiac ganglia and the network of its interconnecting fibers. So it is embedded in the loose areolar tissue within the retroperitoneal space, posterior to the stomach and the pancreas, close to the celiac axis, and it's separated from the vertebral column by the crust of the diaphragm. So this is important to know that it is separated from the vertebral bodies by the crust of the diaphragm. That's how the approaches vary. So that it's located roughly between the T12 and the L1 disc space, or it can go up to the L2 vertebral body occasionally. It surrounds the celiac. Is there a pointer? So it surrounds the celiac artery or the root of the superior mesenteric artery, and is in front of the pleura of the diaphragm, and it is at the junction where the thoracic aorta becomes the descending aorta and comes into the abdomen. If you look at the cross section, posterior to the celiac plexus, you have the abdominal aorta and the vertebral body. To the right, you have posterior to the celiac plexus, you have the aorta and the vertebral body, the L1 vertebral body. To the right laterally, you have the inferior vena cava, and posteriorly you have the kidneys. In front, you have the stomach and the pancreas. And if you do a posterior approach, from posterior to anterior, you would encounter the skin, the latissimus dorsi muscle, the serratus posterior inferior, the erectus spinae, and the intercostal muscles. So the structures innervated by the celiac plexus are all the structures that are derived from the embryonic foregut, which is all the upper abdominal viscera, including up to the proximal part of the transverse colon. Looking at the functional anatomy, celiac plexus is composed of the pre- and the post-ganglionic sympathetic, parasympathetic, and the visceral sensory afferent fibers. So the pre-ganglionic sympathetic fibers, they are carried from the greater, lesser, and the least splanchnic nerves. They relay in the celiac ganglion. So that is the supply from the T5 to the T12 sympathetic fibers. And then it receives the parasympathetic fibers from the celiac branch of the right vagus nerve. So the indications for doing a celiac plexus would be basically all the upper abdominal malignancies or retroperitoneal malignancies, and to add to it, it could be also cases of chronic or acute pancreatitis. And the contraindications for celiac plexus would be patient refusal, coagulopathy, anticoagulant therapy, or patients on antiplastic cancer therapy, or cases of bowel obstruction, or there's an ongoing infection in the patient, or any abnormal anatomy which would avoid from doing the block, something like a celiac artery aneurysm that you should consider before doing a block. So, preoperatively, you would prepare the patient by stopping the anticoagulation therapy as per the ESRA guidelines, and you should continue antihypertensives and all the other regular medicines that the patient is taking. Then hydration and electrolyte balance should be corrected, especially because you are doing it in certain very frail patients and who are terminal cancer patients. And opioids should be continued during the procedure. The monitoring required to do this procedure would be pulse oximetry, non-invasive blood pressure, and ECG monitoring. So the various approaches to this block would be, you could do it retropleural. That means it could be, so this is the crust of the diaphragm, and you're very close to the vertebral column. So if you're behind here at this point, you're behind, so you're retropleural. So here it could be, if you're doing a celiac plexus, but it could be more, you have to give a bigger volume, and it would be more like a splanchnic nerve block. When anytime you cross the pleura of the diaphragm, you could be transpleural, peri-aortic, pre-pleural, or you could be transaortic. So this is where your celiac ganglion lies, and if you're in front, so the second, third, and the fourth approaches come into play. So the way you could do this block, the methods could be either blind without any guidance. It used to be done, but I would not recommend it anymore. And you could do it fluoroscopy guided, CT guided, or you could do it using endoscopic ultrasound. It's mainly done by the endoscopist, where they pierce the mucosa of the stomach to be in the celiac plexus and to inject there. Okay, now, like I said, the retrocrural approach, here you are behind, so this should be your needle position. If you are peri-aortic or pre-crural, your needle position should be in front of the diaphragm. So to perform a block, you would need a 22 gauge 13 centimeter spinal needle. For doing the diagnostic block, you could do you have to inject local anesthetic, 20 to 25 ml of local anesthetic with or without steroids. And this would be the kind of dye spread and the local anesthetic spread you would get. And for doing neurolysis, you could use 10 to 12 ml of absolute alcohol or 6% aqueous phenol or 25 ml of 50% ethyl alcohol. Post-procedure should monitor the patient hemodynamically and for respiratory function, record their pain scores, and prior to discharge, make sure the patient is vitally stable and is able to ambulate. Now, the post-procedure instructions to be given to the patient would be to report for any swelling, tenderness, breathing difficulty, diarrhea, or constipation. So the side effects of this procedure could be anything like hemorrhage, bleeding, hemorrhage infection, or trauma to any of the surrounding structures. One should be careful. And you may have hypotension, orthostatic hypotension, because a sympathetic ganglion block, or you could have diarrhea. These are the main things you should be careful. So this is a short video showing you the procedure.
This is the facility required to do a celiac plexus neurolysis. These are the disposables required, including absolute alcohol for neurolysis. Placing the patient in prone position, visualize T12 and L1 vertebral levels using fluoroscopy. Now oblique tilt the cilium on ipsilateral side by 15 to 20 degrees. This is the L1 vertebral level with our area of interest. Mark the desired entry point of the needle as shown in the picture. Insert the 22 gauge long needle using coaxial imaging. Now visualize the depth of the needle with lateral imaging until the needle touches the lateral border of the body of the L1 vertebra. Advance the needle further anteriorly. This is a schematic representation showing that the needle could be peri-aortic or transaortic. Appreciate the aortic pulsations on the needle. Repeat similar procedure on the other side. Advance the needle beyond the anterior vertebral border. If you happen to encounter blood, advance the needle further until blood stops to be anterior to the aorta. This is the final position of the needles. Contrast is given, which is confined to the midline and concentrated near the L1 vertebral body as a smooth curvilinear shadow.